I've got, okay, I'll just admit someone else, Simon Peter. Yeah, welcome everyone to this pediatric talk. I mean, I want this to be interactive and for you to ask questions today if you want to, because I'm really going to discuss a couple of cases, and I wanted to, for that, rather than give a didactic talk about a particular topic, I wanted to illustrate some principles of the management of seriously ill children that I think we can apply no matter where we are, whether you're in an intensive care unit or in a district hospital. You can apply these same principles everywhere, I think. And I wanted to just describe some of the principles of the intensive care management of common pediatric problems, and just use a couple of cases to illustrate that. So we welcome everyone today. We've got a number of people online. I think welcome to Dr. Vatuna and Dr. Khaled from Rabaul, and we have Dr. Rachel Master from Kimbay, Dr. Wilma Luan from Madang, the team in Honiara, welcome you guys, and Dr. Alan Herrero from Alatau, and Dr. Mane Amini from, Mane, I think you're in Port Moresby, is that right? And then Dr. Simon Peter, who, you'll have to tell me, where are you from, Simon?
What was Pomjen?
Pomjen, and Mane too, eh?
Yes,
from
yes.
Pomjen.
Okay, thanks. Okay, well, look, we'll make a start. I mean, I wanted to, about 100 years ago, it's useful to look back on what, you know, on history sometimes. A person who used oxygen for the first time I'll just admit Yagi, the doctor who used oxygen for the first time in the management of patients, this was in 1917, so this is over 100 years ago. He used oxygen, especially in, I think you are familiar with, during the First World War, there was a lot of gassing of soldiers, and he found that oxygen was a really useful therapy for those patients. But he said this about oxygen, he said, the respite afforded by such measures is the temporary administration of oxygen is utilized for recuperation, which just means that oxygen and many of the things we do, many of the therapies we apply, are really just temporary support until the body heals itself. And I think most of what we do is temporary support to the different organs of the body until the body can heal itself. And I think I always think of that as being what intensive care is. It's not magical. It doesn't cure the patient. You know yourselves, when patients have say COVID, pneumonia, we provide support to their lungs until the body can heal itself. That's what intensive care, a lot of intensive care is. Intensive care is about vital organ support. It's like, as I say, a bridge to natural recovery. The body has to heal itself. And so in providing a bridge to natural recovery, we want to make sure we're not doing any harm along the way. There is some technology involved, like using oxygen or pulse oximeters, but mostly I think intensive care is about meticulous attention to detail. We have to have a systematic approach to meticulous attention to detail on ward rounds and in our thinking. Yeah. The other thing that people don't understand about intensive care and medicine in general is that there's one therapy that's really important, and that's time itself. We have to give the patients time to recover, time for their body's natural healing to occur. And mostly that occurs, you know, 90% plus times that natural healing will occur if we provide organ support and give the patient enough time. If you're thinking about things in an intensive care way, you need to avoid bad things happening. And oftentimes, bad things happen to our patients, whether they get a nosocomial infection or someone gives the wrong drug or we give too much fluids or something. So our focus really in intensive care has to be about a focus on safety, really a focus on safety, providing that time the patient needs for a bridge to natural recovery. It is a multi-system approach to clinical care, which I think we all do, but we need to think about even systems we sometimes don't think about, like the kidneys and how, or or other systems. We need to, the liver and how the drugs we use or the therapies we use impact upon those systems, the hematological system, etc. It starts with an ABC approach, and I'll explain at the end how I think a systematic approach to patients that we see who are seriously ill. It doesn't have to be in intensive care, but it has to be, you know, in patients who are seriously ill. I think that when we think about things in intensive care, we think about an approach to clinical problems based on an understanding of pathophysiology. And that's what, in pediatrics, we have to have an understanding of the pathophysiology of the disease and the natural history of the illness, how long the child is likely to take to recover, etc., and what it takes for the child to recover. These are all very important. And intensive care, like pediatrics in general, is multidisciplinary. So we don't just use, like, it's not just doctors helping the patient, but doctors and nurses working together, and HEOs and physiotherapists, allied health, and other people helping the patient to get better. Pharmacists are very important. So, I mean, just like all pediatrics, we should be multidisciplinary in our approach. Okay, so they're just principles, I think, of intensive care that maybe you hadn't thought of. They're principles of the system, the systems that we need to have in our hospitals for the care of seriously ill children. I'm just going to talk about two cases I've seen recently that I thought outline some of the principles that we apply. And these cases will be familiar to you because they're conditions which that we see very frequently. Look, this was a 7-year-old boy. He was from Samoa, and he presented with lethargy, vomiting, and seizures for 2 hours. He'd been lethargic for most of the day. He'd had a fever, although the temperature hadn't been measured, but he had felt hot to his mother. And then he had started having seizures that hadn't stopped for 2 hours. By the time he reached hospital, his convulsions had been going for 2 hours. He was at the time poorly conscious. His oxygen saturation was 88% and his lips were dusky. His heart rate was 190 per minute and he had cold hands and feet. Now, he went on to have a CT scan of his head, and this is what it showed. I wonder if anyone could just maybe talk about what you think the CT scan might show. Well, perhaps anyone, based on just the clinical picture, a 7-month-old boy with lethargy, fever, vomiting, and seizures for 2 hours, who comes in poorly conscious, has dusky lips, saturations of 88, significant tachycardia, marked tachycardia, and cold hands and feet. What do you think's going on? If you think about it based on the brief history, the triage history, and the initial examination, what do you think could be going on?
Prof, looks like child has got sepsis, septic shock.
Yes, that's right. Yeah, this is a serious bacterial infection until proven otherwise, isn't it? It's septic shock until proven otherwise. That's right. And it might be there's something else going on, but it's very important to sort of think about the child as if they've got sepsis and think about it in a multi-system way. Now, he had this CT scan. Can anyone suggest what this might actually show? This would be the CT scan of many of the patients we see who have this type of presentation. And I just want you to have a look at it. What can you see on the scan? Or what can't you see?
There's lots of Jara and Sakai pattern.
Yes, that's right.
I think that.
So go on, Andre, what do you think?
Yeah, I think there's lots of Salkai and Jara pattern.
That's right. If when we look at a CT scan, we normally see the sulcal, the sulci and the gyri pattern of the cerebral cortex. We also normally see the the ventricles being a little bit larger than this, don't we? It depends on the projection on the level, of course, you're looking at it, but usually you see the ventricles being larger. And usually you see a difference between the grey matter and the white matter being the deeper structures and the grey matter being the cortex. So we would say there's a loss of grey-white differentiation. We would say there's a loss of the normal sulcal and gyral pattern, and we'd say that the ventricles are somewhat effaced. And what that does is add up. This CT scan was done very early in the first couple of hours of this child's presentation. And so what would you be worried about? You've heard the triage history, you've seen the brief examination, and now you've seen the CT scan. What would you be worried about?
Cerebral edema.
Yes, that's
Increased
right.
intracranial forces.
Exactly. This boy has cerebral edema, and the question, of course, is whether the cerebral edema is just because he's had seizures for 2 hours, which you can get cerebral edema because of seizures for 2 hours, or whether the cerebral edema might be due to what else? What else could cerebral edema be due to in this child? Maybe someone else can have a go.
Meningitis or inflammation?
Yes, that's right, Eleni. Yeah. This child could have meningitis. He could have cerebral edema related to prolonged seizures, status epilepticus. But yes, it's a worry that this child might have meningitis. And I think for many of the patients that we see with an acute presentation like this, we don't really need to do the CT scan to know that the child's likely to have some degree of cerebral edema. We can almost assume, based on that clinical picture, that this child either has cerebral edema or is at risk of cerebral edema. So it's nice to have a CT scan that proves it, that shows it, but it's also perhaps in a child who's poorly conscious, who's hypoxic, who's tachycardic, who's got cold hands and feet and with signs of septic shock, like Andre said, then it's safe to assume that the child has some degree of cerebral edema. This boy ended up very quickly in a 12-hour period having streptococcus pneumonia in blood cultures growing in his blood culture. So you would think that he's got pneumococcal bacteremia, and maybe, as you said, Eleni, that he's got meningitis due to streptococcus pneumonia, which is, as you know, the commonest cause of meningitis. So the question is then what to do about it. How to treat this patient. Can anyone suggest what are the key steps in treating this patient? Where would you start?
Prof, I think we'll just do the ABC airway and breathing circulation first.
Yes, that's right. I think it's good to start. It's good to have a systematic approach where to start, and you should start with the airway, the breathing, and the circulation. They're the first things, and then keep going from there. I'll explain how you keep going from there, but the airway is very important. I mean, airway, breathing, and circulation. Now, when you're thinking about which children should be in a intensive care or a high dependency area in your ward, then you should think about not so much the diagnosis, but the severity of illness. And in the World Health Organization Pocketbook of Hospital Care for Children, it talks about emergency signs. And these are the emergency signs: obstructed breathing. So I'll just admit a few more people. The emergency signs are obstructed breathing, severe respiratory distress, central cyanosis, signs of shock, coma, convulsions, and severe dehydration. And this boy, within the first 2 minutes that this boy has 4 of those signs. All you need is one of those signs for it to be an emergency, for you to stop further assessment and provide some emergency treatment. But this boy had 4 of those signs. So I think if you use these signs as an indication that the child needs to be in a high dependency or intensive care area in your ward, then that's a good start. This boy had 4 of them: central cyanosis, signs of shock, didn't he? Signs of shock with his tachycardia and cold hands and feet. He had signs of coma because he was poorly conscious. He had been convulsing for 2 hours, and he had central cyanosis. So there he has emergency signs. When we think about children who have meningitis, then there's when we're thinking about the support for the ongoing support for those children, then you need to think about several things. One is what the primary brain injury is, and the primary brain injury in meningitis is inflammation or infection, isn't it? It's inflammation or infection and all the problems related to that. But then we need to think about protecting this boy's brain from secondary brain injury. And you can apply this to any seriously ill patient, any patient who's got an impairment of conscious state, any patient who's got status epilepticus. Then it's our job as doctors to try to protect this child's brain from secondary brain injury. And you can get secondary brain injury from hypotension or hypoxia or hypoglycemia or hypercarbia if his carbon dioxide level goes too high, or seizures, ongoing seizures, or cerebral edema, or hyponatremia. So all of those conditions, those complications can lead to secondary brain injury. And for many of the children that we see that have a deterioration after they come into hospital, the reason why they deteriorate is because of secondary brain injury that we haven't fully prevented. And so our job is to prevent that. All right, we can't do too much about the primary brain injury apart from giving antibiotics, or if a child's got an intracerebral hemorrhage, subdural, then draining that. We can do something about the primary brain injury, but we can do more to prevent secondary brain injury. And so any child with meningitis, of course, we give antibiotics and we follow the airway, breathing, circulation, but that's all focused around trying to prevent secondary brain injury. So the sorts of things that we can do for this boy, I think there are some things that are hard to do, and then some things that we can do. And I think that we can provide neuroprotection. We can try to protect the child from having a secondary brain injury. And so what can we do? Well, we can nurse the child 30 degrees head up, and that sometimes requires needing to tilt the bed, or sometimes just putting pillows under the child to elevate the child's head, just to make sure that the child's 30 degrees head up. Why is that important? Because it reduces cerebral edema, and it improves venous drainage of the head, and it's the optimal angle. 30 degrees is the optimal angle to ensure perfusion of his brain, to ensure that the arterial perfusion of his brain is not blocked by the cerebral edema. So have a patient 30 degrees head up. We need to pay attention to his airway, because if he's got a blocked airway, he might get hypoxia or hypercarbia. And they're 2 causes of secondary brain injury, hypoxia and hypercarbia. We need to pay attention to his breathing, don't we? And that means 2 things. When you think about breathing from now on, I want you to think, when we're going through the ABC, then there's 2 parts to breathing. And one part is oxygenation, that is how much oxygen you have to give to get for this child to have an adequate saturation. And the other thing is ventilation. And the 2 are related, but they're different, right? And I'm not talking about mechanical ventilation on ventilators. I'm talking about the way the child's chest moves and the adequacy of their ventilation. Because a lot of children we see in this position will have inadequate ventilation. And they may have inadequate ventilation because they've got obstructed breathing, or because their conscious state is poor and they're not making enough chest movement, or they may have hyperventilation. They might have, perhaps with fast but shallow ventilation, they might have some impairment of ventilation. So when we are assessing a patient's breathing, we need to assess their oxygenation and the adequacy of their ventilation. And if a patient has impaired oxygenation, we can give more oxygen. If they've got impaired ventilation, then we need to try to find the cause. And sometimes it'll be as simple as pulling the jaw forward and helping the child breathe a little bit better. Sometimes it'll be a bit more complicated by helping the child breathe. I'll just admit someone else now. Sometimes it's a little bit more complicated in trying to help the child breathe with some CPAP or something else that might assist their ventilation. So airway, 30 degrees head up, airway, breathing, circulation. So I want to, sometimes I think we don't assess a patient's circulation very adequately. And I want you to see the value of a proper assessment of the child's circulation. No one marker of circulation is infallible. Like, you can't say just because the heart rate is a certain rate that the child is okay, or just because the capillary return is a certain level, the child's okay. You have to look at all the markers of the circulation and then put them all together, because each one of them is confounded by some other problems. So I think feeling the hands and the feet are really important in any child. I feel the hands and the feet. You want to feel whether they're warm or they're cold. And at the same time, you can check the capillary refill and you can feel the radial pulse. And I think if you do that properly, the hands and the feet, but when I feel the feet, I feel the posterior tibial pulse and the dorsalis pedis pulse. Make sure you try to feel the pulses of a child, the peripheral pulses, and get used to, if you examine enough children, you'll get used to feeling the pulses and feeling what they feel like, and you'll get used to feeling what a normal pulse volume feels like. I think this is really important, and we don't do it well enough, and we don't teach other people to do it well enough. In a child like this with a CT scan like this or with that presentation, then this is a new concept perhaps, but we can assume that his intracranial pressure is high. With that degree of cerebral edema, you can assume our intracranial pressure normally is somewhere between 5 and 10 usually, and then if we get excited or stressed, it might go up to 15. But if you've got a CT scan that looks like this, or you've got a clinical presentation with pneumococcal meningitis or suspected meningitis, then you can assume that his intracranial pressure is about 20, right? 20 millimeters of mercury. So what that means is, if his blood pressure, when you measure his blood pressure, is only 45, then his cerebral perfusion pressure, that is the blood pressure, the mean blood pressure minus the intracranial pressure, is only 25. And so that's not enough. That's not enough to protect him from secondary brain injury. And so for patients like this who have a poor conscious state, they present with prolonged seizures, you can assume that his intracranial pressure is around about 20. And so therefore we should aim for a mean arterial pressure of around about 60 millimeters of mercury. And so for a child who's got septic shock, that's sometimes not easy to do. And sometimes it will be hard to do that with just, sometimes the patient's own blood pressure might only be 40 or 45, a mean of 40 or 45. And for some children who are otherwise well, we might say that's enough. But for children who've got are at risk of cerebral edema, then with an intracranial pressure that can be assumed to be 20 millimeters of mercury, we want to make sure their cerebral perfusion pressure is about 40 millimeters of mercury. I hope that makes sense. I know these are new concepts, the idea of assuming a cerebral perfusion pressure, but I think it's quite important in understanding what happens to many of our children that have meningitis or some febrile encephalopathy. One of the reasons why they deteriorate is because we don't pay any attention to their likely cerebral perfusion pressure and their intracranial pressure. Okay, that's the circulation. We'll talk a bit more about that a little later. But then we need to avoid fluid overload in the patient, don't we? He's already got cerebral edema. Is it possible for people to mute unless you've got a question? It's okay if you've got a question.
Feeling there. I told Nimi to send me the list, but she never sent me the two stops working there.
Yes, they at Rumgini. Yeah, they've been there several weeks.
Send me.
You want the list? The name?
We'll keep going. It's
I want the list of those three.
Those ones I think are Valencia.
Right, mute them.
We have to pay them for their and also what to send the vaccine. Not vaccine.
With all children who've got who've got cerebral edema, we need to make sure we're avoiding fluid overload. And most of these patients don't need a lot of intravenous fluids. And so when we think our,
I told Dr. Bowden,
who's got them?
these guys are setting something. How, I mean, you know, they're already setting something there. They need to have the test it.
Yes, to actually test it.
So, we have to get some of these things out.
Okay. Yeah, this is really important that when we calculate the amount of fluid a child should receive, if they've got suspected meningitis or cerebral edema or febrile encephalopathy or cerebral malaria, we really want to avoid fluid overload. So they're calculating the fluid requirements based on the 4-2-1 rule. That is 4 mils per kilo for the first 10 kilos, 2 mils per kilo for the next 10 kilos, and then 1 mil per kilo thereafter. That is mils per hour. That is too much fluid. And if you gave that much intravenous fluid to this child, he will get very edematous. And so in a child like this, you give no more than half the calculated fluid. And most of these children need very little fluid in the first 24 hours. We need to just make sure they're not getting hypoglycemic, but you just really want to avoid fluid overload because it'll worsen their cerebral edema. So we should only give isotonic fluid to these patients, not giving 4.3% dextrose and 1/5 normal saline, because that will cause their sodium to drop and it'll cause water to shift inside. It'll cause water to shift inside their cells. And we can protect their brain by reducing the risk of further seizures with anticonvulsants. So they're all the things that we can do. 30 degrees head up, make sure the airway is okay, assess their breathing, both oxygenation and ventilation, assess their circulation, aim for a cerebral perfusion pressure that's at least 40 in a young child. So that means their mean blood pressure must be 60. And sometimes we need to give other medications to do that, such as adrenaline. We need to avoid fluid overload and only give isotonic fluid so we protect the serum sodium. So the serum sodium doesn't drop further, and then we need to give anticonvulsants. So they're all the things that we can do. And again, the best anticonvulsant to give is one that's not going to reduce the child's conscious state. So that's neuroprotection for these patients based on the airway, breathing, and circulation. When we think about the patients who should be managed in a intensive care area in the ward, then I think it's useful to think about the conditions that should commonly come to our high dependency areas. So if a child's got an obstructed airway, either from croup or quinsy or a peritonsillar abscess or a foreign body, if they've got an obstructed airway, then they need to be in an area where they can receive intensive care support. If their airway's at risk, if they've got a poor conscious state, then that's just as dangerous, isn't it? So they should also be in a high dependency area in the ward. In terms of their breathing, if they've got severe respiratory distress or hypoxemia, that could be anything from pneumonia or asthma or TB with severe acute complications or HIV with pneumocystis or HIV with severe pneumonia, or even for post-operative respiratory monitoring in some children that are likely to get apnea in the post-operative period. They're all patients for whom it's good to have them in a high dependency area in the ward, not to just spread them out throughout the ward, but have them in a close area. If they've got a circulation problem, like we said, sepsis or dehydration, or if they've got heart failure, then they also, from any reason, congenital heart disease or pericardial tamponade, or pulmonary hypertension or rheumatic heart disease or anaphylaxis, all of these patients really, it's good to have them in the acute high dependency or intensive care area in our ward. So that's the first case. I wanted to present a case about a child with a neurological problem. This boy got all of that treatment and he did very well. He's still in the hospital now, but he's had all the treatment. He turned out to have pneumococcal meningitis, of course, and with that basic treatment, he got much better, and his neurological responses are pretty good now. So that's a good outcome. I wanted to just talk about one more child who's a little bit different, but again, it demonstrates if you have this approach to patients, then you can just work through their problems, and sometimes just supporting the organ systems during for a few days can lead to the natural recovery of an illness. So this was a 2-year-old boy who was one of twins, and he'd been previously, as far as we knew, quite well. He wasn't a very good eater, and he'd actually lost weight in the recent 12 months. And he'd been unwell for a little while, for a couple of weeks, and he'd had a history for about 2 weeks. Hard to get the history from his mum, but about 2 weeks he'd had not been active. He'd been lying around most of the time, not moving very much. He had bilateral leg swelling, swelling of the lower limbs, and he had fast and rapid breathing. He came in with respiratory distress and with knees that were very swollen, and knees and ankles particularly, but particularly his knees, and he wouldn't weight bear. And so again, this is a relatively common presentation, leg pain and respiratory distress. He'd had no fever at all. What might you think is going on? What would be in your differential diagnosis of things that could be happening to this boy? There's a lot of different things, and no one diagnosis is right. So just maybe some people can suggest some things so that we have, when you're seeing a child like this, you should have in your mind a differential diagnosis, all right? And it could be a list of 5 or 6 conditions that you want to exclude through your further examination and through your laboratory investigations, etc. So what else could be going on?
It's there, malignancy.
Okay, good. Yeah, James, thank you. Dr. Alto, welcome. Yes, he could have a malignancy. What sort of malignancy would give you that? 2 weeks of reduced activity and refusal to walk. What sort of malignancy do you think?
Osteosarcoma.
Sure, it could be an osteosarcoma, but yes, it could be, yes. So that's one possibility. What else? What malignancy were you thinking of, James?
He's pale and is rapidly breathing. So I'm thinking like kid that age, think of common things like lymphoblastic leukemia.
Yes, that's right. It would be a common presentation of a child with acute lymphoblastic leukemia, wouldn't it? To have, you know, a child who's previously well, has a history of being unwell and lethargic, refusing to walk, and has limb pain and swelling. That's surprisingly quite a common presentation of acute leukemia. But there's many things it could be. What else could it be? What else do you think? Anyone else?
Anemia.
Anemia. Good. Yeah. Thanks, Alan. Yeah, it could be the child's got severe anemia. That could account for his bilateral leg swelling and his pallor, couldn't it? And it could account for his rapid breathing. And perhaps he's so anemic that he's lethargic and he's tired and doesn't want to walk. Yeah, that could be it. What else? What else? So we've got acute leukemia. We've got another malignancy like an osteosarcoma. We've got a severe anemia. Anything else?
How about problem with the kidneys?
Yeah, someone's. I think Glenson, you might have said severe malnutrition. I agree. If his we had a vague history from his mum that he hadn't been eating very well for the last year, and he might have severe malnutrition. That's right, and that might account for his bilateral leg swelling, which could be because of kwashiorkor. Quite right, and his pallor might be related to anemia of severe malnutrition. Right, so we have acute leukemia, we have osteosarcoma, we have severe anemia. Anything else? Any severe anemia? What else? What else might be in? Let's have 1 or 2 more in the list of things in our differential diagnosis.
Some kind of kidney disease.
Okay, that's a good thought. Yeah, he could have some kind of chronic kidney disease that's led him to have bilateral leg swelling if he's got retention of urine. Very good. So I think we've got enough to work on, haven't we? We've got acute leukemia, we've got severe anemia, we've got some like solid malignancy like an osteosarcoma, we've got severe anemia, chronic, maybe an acute on chronic kidney disease. That's right. So all of these things could, we might even throw into that perhaps something like a osteomyelitis or some other rheumatic arthritis or something like that that might lead to this sort of problem. So the point is, when you get the presenting problem, you need to think broadly about what the possibilities are. And as we go further in our examination, take more of a history, then we can be a bit closer to the diagnosis. Right? So on clinical examination, this was his leg. I took a photo of his leg, but he was lethargic, certainly very lethargic. He had tachycardia, a heart rate of 180, and he was very tachypneic. He had some grunting breathing. He was severely pale, very, very pale, and had not just edema of his legs, but puffiness around his eyes. I've shown you a picture of his leg swelling, and you can see how his knee is bent, how much his knee is bent. He couldn't straighten his leg any more than that. That was without getting severe pain. And his knees were very, very tender. On examination of his chest, he had moderate respiratory distress with grunting respiration. He had, though, good air entry. You could hear air entry okay, a few crackles, and his saturation was 93% on air. So he was breathing very fast, but had a saturation of 93% on air. In terms of his cardiovascular system, he had a heart rate of 170 to 180, and he had a loud pulmonary second sound. A very loud is when you listen to his heart, the second heart sound was very loud. He had warm hands, but very swollen hands and swollen feet, and an abdomen was soft without a liver or spleen. How does that help us? What do you think could be going on? Does it get us any closer to the diagnosis?
Yeah, maybe malignancy, you expect some liver, spleen.
Yes, that's right, James. So if he had an acute lymphoblastic leukemia, which I agree is probably the most likely malignancy, you would expect him to have a liver or a spleen palpable or have some lymph nodes. He didn't have any of those things. He really had a cardiorespiratory problem with this marked problem of his lower limbs and edema. So you wouldn't rule it out. You wouldn't say it couldn't be a malignancy, but you might say it's less likely because he doesn't have organomegaly in the abdomen. Yes. Any other thoughts?
So it's the leg. So any X-ray done or?
Any X-ray? Yes. Let's have a look at his X-ray. Well, first of all, his full blood examination. So look, I want you to look at his full blood examination and tell me what you think is going on. So his hemoglobin. Can someone have a look at it? Maybe Tina, are you there? Do you want to have a go at interpreting his full blood examination?
His LCH is low. LCH is low.
What do you think's going on? I mean, remember we're thinking about, well, could he have a malignancy or could he have severe anemia? Could he have some other problem, an infection? What do you think's going on? Who would like to try?
Microcytic anemia.
Yes, very good. Was that Glanson? Yeah, I think you said he's got a microcytic anemia because his MCV, what's the normal MCV, min cell volume? What's the normal min cell volume?
80 to 100.
200 femtoliters.
80 to 100.
Again?
FL.
Yeah, it depends on age, doesn't it? But it's around about 72 to 75. And he's got an MCV that's 58, isn't it? And the normal is somewhere between 75 and about 95 or 100. And he's got a very, well, do you consider this just a little low MCV or a very low MCV?
Here, Prof. The MCV is quite low. It's got anisocytosis, very high red cell distribution with reticulocytosis.
Sorry, Andre.
White cell count is normal.
No, before you go on, Andre, maybe you can explain the anisocytosis and his red cell distribution with, because this is quite important in interpreting his full blood examination. Can you explain that?
His RDW is 20.1. I'm not sure whether it's the standard deviation or yeah, coefficient of variation. It wasn't stated here, but I'm assuming it's the RDW-CV. That's why it's 20.1. So it's very high. The normal should be around 12 to 16, if I can remember correctly.
Yes, that's correct. Yes.
Yeah, so it's got
What does it mean?
anisocytosis and reticulocytosis.
Yeah.
Microcytic anemia, so it looks more like iron deficiency.
Yeah. Okay. I want everybody to be clear on this. This is actually a very important point, because we get these full blood examinations all the time, don't we? Most days we see a full blood examination. And I think it's really important that we can interpret it to its fullest extent. And sometimes we skip over these parameters like the red cell distribution width. But you can see what Andre is saying is that this means that he's got a large variation in the size and the shape of the red cells, and you get that when you've got when you've got iron deficiency, you'll have a large variation because you'll have some very small cells and some normal size cells. And how is that different to the differential diagnosis of iron deficiency? How is that different? The differential diagnosis of iron deficiency is thalassemia, isn't it? And in thalassemia, usually the red cell distribution width won't be that varied. It won't be that high because most of the red cells are small. They're not very big, but they're a bit small. Whereas his mean cell volume is very small, like less than 60. That's very small, and his red cell distribution width is very wide. Yeah. So sorry, I wanted to just take time to be really clear about that. What about his reticulocyte count?
The reticulocyte count is very high.
Yeah, it's high, isn't it? What does that suggest?
He's releasing a lot of immature cells into the system.
Yes, it suggests that even though he's got anemia, and maybe even though he's got iron, this would be unusual for just iron deficiency. And the reason it would be unusual for iron deficiency is because normally when you've got iron deficiency leading to anemia, then your reticulocyte count will be 0, won't it? So this is a bit unusual for just iron deficiency. What else do you think about the rest of his full blood count that tells you something about what he could or is unlikely to have?
So he doesn't have malignant. He doesn't have leukemia. He doesn't have leukemia because his bone marrow is functioning well. So he's got a high reticulocyte count and a normal white cell count. So it is something on the peripheries.
Yes, that's right. It suggests that he's very unlikely to have leukemia. It doesn't mean he couldn't have it. Sometimes you see a relatively normal bone marrow, a relatively normal blood film in a child with leukemia, and you do a bone marrow and they've got blasts in their bone marrow, but that's very unusual. And so I agree, he's much less likely to have a malignancy, both because he didn't have hepatosplenomegaly and because his blood film looks like it's got a normal differential. This looks a normal differential. And it also makes it less likely that he's got, what else? What other conditions does this blood film make it less likely that he's got?
He could be bleeding.
Yes, he could be bleeding. That's right. He could be bleeding, and that's why his hemoglobin's low, and that's why his reticulocyte count is high.
Sites are high.
Yes, that's right. His reticular, and what else could give you a high reticulocyte count? So there's only a few things, isn't it? One certainly bleeding will do it if you've got enough hematinics to make new bone marrow. And what else can give you a high reticulocyte count? If he had hemolysis, that could give it to you, wouldn't it?
Hemolysis.
Yeah, if he had hemolysis, then the bone marrow is trying to make up for the rapid lysis of red cells all the time. So it's making lots of new red cells, which are reticulocytes, and putting them out. So hemolysis and bleeding are the two things, ideally, you should think about if a child's got a high reticulocyte count. But there's something else. I mean, maybe it's obvious to you, but we don't say it. Sometimes the things that are obvious we don't say, but we should say them. There's no evidence on this blood film, on this differential of an infection, is there? I mean, his neutrophil count's not high or low. It's not high and it's not low. His lymphocyte count is okay. His monocytes are normal, and he doesn't have any of the immature forms of neutrophils. So if he had lots of band forms, or he had myelocytes or metamyelocytes, then we'd be thinking along the lines of, well, this perhaps could be either a hematological malignancy, or it could be severe sepsis, right? And so even though he presented with, severe respiratory distress, limb pain, refusal to walk, swollen legs, there's not much evidence here that he's got a severe infection, is there? Because his blood differential looks okay, and his platelet count is in the normal range. If he had severe sepsis, he wouldn't necessarily have a platelet count in the abnormal range, but if he had a platelet count of 800,000, or if he had a platelet count of only 80,000, 80 or 800, then it would be more likely that this is sepsis. So I think we can look at this blood film and we can say, well, he's got a low MCV, he's got a high red cell distribution width, he's got severe anemia, he may have iron deficiency, but his reticulocyte count is high, but there's no evidence of him having a severe infection, like osteomyelitis or septic arthritis causing his knee swelling. So in the first couple of hours, we transfused him with 140 mils of PAC cells because he had such a severe respiratory distress. And predictably, during that time, his respiratory distress didn't improve. This was his chest X-ray. And I want you to have a look at this X-ray. This is, I think, a very interesting chest X-ray. Can someone, perhaps who hasn't made any suggestions yet, have a look at the X-ray and tell me what you see? Does anyone want to have a go at interpreting this chest X-ray? It's not very. There's no hidden hidden pathology. It's all there. You just have to go through the X-ray and explain what you see.
Maybe I'll just give a try.
Yeah. Benji, good afternoon.
Good afternoon. I think the film is a bit rotated, but it makes the cardiac shadow look a bit enlarged.
Yes.
With some probably like a plethoric lung fill a bit bilaterally. I mean, that's what I think.
Yes, that's right. The heart looks large. I mean, these are simple things that you just the heart looks large. And how are you going to assess the heart size, Benji?
You'd measure the CT ratio.
The cardiothoracic ratio. So we'd measure the heart, the diameter, the largest diameter of the heart, and we'd measure the largest thoracic diameter. And do you think that's more than half?
Yes, I do.
Yes, I agree. So there is evidence of cardiomegaly. And Benji, you said that was evidence of plethoric lung fields. Yeah, particularly where is the plethora?
Mainly around the perihilar area, but yeah.
Yeah, perihilar and the upper zones, isn't it? It's both upper zones. You see this, remember in adults when we were assessing adults x-rays for heart failure, there's this concept of upper lobe venous diversion. And that means there's more congestion of the pulmonary veins in the upper lobes. And it's rather similar in this x-ray. There's pulmonary plethora and there's some upper lobe venous diversion, right? But there's one other sign I want you to look for. And the reason I wanted to show this x-ray is because of this additional sign. So we have some evidence that he's got, Benji, what would you say is likely to be the problem? Just conceptually on this x-ray, how would you say it?
I would think there's some cardiomyopathy, probably with some heart failure.
Yeah. Well, I think rather than saying he's got a cardiomyopathy, we should just say he's in heart failure, because it could be, of course, a cardiomyopathy, but it could be lots of other things too. And so, but there's one other sign I want you to see, and that is, I want you to look at the trachea. Look at the trachea, and then look at the branching of the bronchi coming out here. The bronchi comes out here, and it comes out here. Right now, I want you to, from now on, try to look at the angle of the bronchi. Right. What this is called the angle of the carina, right? And the angle of the carina should normally be less than 90 degrees, right? So if you look on lots of x-rays from now on, you'll be able to see that the angle of the carina is normally less than 90 degrees. I've drawn it in this one, and I just want you to look at what the angle is. See the angle here? See the angle of the bronchi? Yeah, you can see that it's just more than 90 degrees. And what do you think that means? This is a very useful sign, I think, that we should look for. It's just the same as looking at the cardiothoracic ratio. Also looking for pulmonary congestion and upper lobe venous diversion. But the angle of the carina is a very important sign. And can anyone tell me what it means? What sits underneath the carina? What's underneath? Just below? It's the left atrium. Okay, so the left atrium sits just underneath the carina. So when you've got heart failure with an enlarged left atrium, then what that does is splays the carina. And so normally the carina would be more on an angle like this. The right main bronchus comes down there and the left main bronchus comes off like that, right? Down like this. But you can see it's splayed out because the left atrium is very enlarged underneath it, right? So that's why it's more than 90 degrees. So from now on, when you look at x-rays, just look at the carinal angle. Sometimes you'll see it enlarged when you've got a big heart. That's all. And the reason for the angle of the carina is that if you've got it more, if the carinal angle is more than 90 degrees, then that suggests that the left atrium is very enlarged. So in conditions like mitral regurgitation, in anything that gives you a large left atrium and cardiomegaly will splay the carinal angle. So from now on, just look at your x-rays like that. So this boy had severe respiratory distress. And remember I said he had a loud pulmonary second sound, that was a characteristic feature, a very loud pulmonary second sound. And on his echo, he had suprasystemic pulmonary artery pressures, right, with a right ventricular systolic pressure of 75 millimeters of mercury. His right ventricle is very dilated and hypertrophied, and he had what we call curvature of the interventricular septum to the left. And consequence to that, he had reduced left ventricular function and a dilated left atrium. And that's why he had splaying of the carina. So his echo suggested that he had severe pulmonary hypertension. So what might cause that?
Prof, is there pruning of the pulmonary vessels on the right lung field?
No,
I'm not too sure.
No, thanks, Andre. No, there's not actually. And in fact, there's the opposite, isn't there? There actually looks like there's enlargement of the pulmonary vessels rather than pruning. And so I think that sometimes you'll see pruning, but no, this is actually probably, if anything, his pulmonary arteries are very large rather than pruned. Sometimes you'll see that pruning, but sometimes you won't. Yeah. And so he went on, we'll keep going for a moment. He went on to have this X-ray. See, remember I showed you the picture of his knees. So we've established that he's got heart failure, severe anemia, probably iron deficiency. He's got some signs of pulmonary hypertension, and he's got this X-ray of his knees. What do you see? Do you think they're normal? Remember, this is a boy who's had refusal to walk for 2 weeks, and he's got swollen knees that are fixed in flexion. You can't really straighten them out. It was hard to actually get these X-rays, but you can't straighten them out because he's got such tenderness of the knees. What can you see? But I want you to have a look particularly at when we're looking at bones, we should be looking at at all the different parts of the bone. So this is the bony cortex, and this is a normal sort of cortex here, isn't it? You can see that it's not too thin, it's not too thick. The medullary cavity of the bone also looks reasonably normal. Some of these lines in the medullary cavity are just blood vessels coursing through the bone. And then when you get up to what's this part of the bone? The metaphysis and the epiphysis, isn't it? This is the epiphysis and the metaphysis. What do you think about the metaphysis? Just look here.
It looks eroded.
Yes, that's right. It looks eroded, doesn't it? Look, it looks like there's osteolytic lesions around the metaphysis of the bone. That's right. And it looks like there's osteopenic lesions of this epiphysis actually, and it's not smooth, it's not normal, is it? You can see it both in the distal femur and in the proximal tibia. You can see it in both the left and the right side. Yeah. So what could do this? Benji, you said it looked eroded. What would you think about?
I can't think of anything right now. Right now, I'm actually thinking of not RTA, but I can't think of anything else.
Okay, that's okay. I mean, if this was just one bone and he had a fever, then this would be consistent with him having septic arthritis, wouldn't it? You can get, all it's showing is that there's inflammation and erosion of bone. There's not an expansion of bone. So the person who said he might have an osteogenic sarcoma, you can virtually exclude that because the area most affected, there's no expansile lesion. There's just an erosion of bone and periosteal elevation. So this would be consistent with a septic arthritis or an osteomyelitis. But the fact is he didn't have signs on his blood film of an infection. So it makes it less likely. if you saw this in a newborn baby, what might you think it could be? Anybody?
Some genetic condition.
Yeah, that's right. And it could be genetic, although often genetic conditions don't have so much sort of inflammatory, ragged erosion of bone. They will have like maybe widened or abnormal metaphyses and epiphyses, maybe, but not so much an apparent inflammatory erosion of bone with new bone formation and periosteal elevation and spicules of bone. This is very ragged, isn't it? So something else that might be congenital that might cause this sort of bony lesion.
Congenital syphilis.
Very good, yeah, congenital syphilis. This would be consistent with, if you saw it in a newborn baby, consistent with congenital syphilis. Dr. James, you mentioned, James Alto, Dr. Alto, you mentioned a condition early on that would be consistent with this. What else would be consistent with this sort of bony erosion lesion in an older child?
Trevor, no, I can't think. I can't think of that.
No, you're right with acute leukemia, because you can get these bony erosion changes with acute leukemia, and so all this tells you is that there's some inflammatory bony erosion of bone with new bone formation, osteopenia. It could be acute leukemia, it could be syphilis, even late presentation of syphilis, and it could be osteomyelitis or septic arthritis, but it's unusual for it to be bilateral, and it's unusual for it to present without a fever or other signs, right? Okay, so, but there's one condition that will give you all of these. So we've thought about leukemia. We didn't think about rickets. Rickets will give you that type of expansile lesion of the distal metaphysis, and syphilis, but scurvy is something that will give you it as well. And we thought maybe this boy's got scurvy. And so in the end, this boy had scurvy. He had vitamin C deficiency, and I'll explain. We measured his vitamin C level, and it's very low. But he also had iron deficiency and zinc deficiency and thiamine deficiency. He had some severe malnutrition, and he'd lost weight over the last year. And this is actually quite typical of scurvy. It's rare to get this scurvy to such a severe degree, but that's what the X-rays were typical of. And also, you might wonder, well, why did he have such severe heart failure? And anyway, we treated him with very simple measures. So vitamin C, multivitamins, thiamine, a blood transfusion, oxygen, frusemide, and a little bit of low-dose adrenaline for 12 hours, and then some iron. That was all he received. And within 24 hours, his respiratory distress had gone down. He was able to come off CPAP. And within 48 hours on a follow-up echo, his pulmonary artery pressures had decreased on echo, and he had good biventricular function and no more signs of pulmonary hypertension. So this sort of child might have been assumed to have just a respiratory infection, just pneumonia, and been treated like that. But in fact, he had scurvy. You can tell by a systematic approach to going through the possibilities. And the reason why he had such severe pulmonary hypertension was this, that vitamin C is very important for the production of nitric oxide. If you don't have vitamin C, then you won't have nitric oxide production. And nitric oxide, as some of you all know, is what leads to pulmonary vasodilatation. And if you don't have nitric oxide, you get pulmonary vasoconstriction and you get right ventricular failure, which is what he had, right ventricular failure with then left ventricular failure. And this is the chemical formula for the production of nitric oxide, but it really relies on the presence of vitamin C. And so in children who have severe scurvy, then sometimes they can have severe pulmonary hypertension and heart failure. And so I found this child interesting, because I think when we think about pulmonary hypertension, for example, in patients with severe pneumonia in the highlands of Papua New Guinea who we think it's just because of their altitude or just because of their pneumonia, then it might be for some of them because of their nutritional deficiency, whether it's vitamin C or whether it's thiamine deficiency. There's a number of different, especially thiamine actually, but for complicated reasons related to betel nut chewing, that those patients might be thiamine deficient. And so I think it's just important we think about other things besides just infections and things. So nutritional abnormalities can lead to severe respiratory or cardiac problems. Right. So that's that case. I just wanted to go through two cases. One, a sort of a complicated neurological case where we had to provide just good basic intensive support with a systematic approach, and a child who had cardiorespiratory problems that when you think it through, then you can find fixable problems. And I sent this around a document around with the invitation to this talk. I won't go through it all, but I think we can have when we're doing an assessment, a ward round assessment of critically ill children, then we can have an approach to them that's based on a systematic approach to the examination. And so I always think about the airway, the breathing, the circulation, the D for disability or their neurology or their response to pain, D for also for their drugs. I always check the doses and work out which drugs are not needed anymore. I think E for exposure and environment, so their temperature, look at their cannulation sites, decide whether they still need their IV drip, look for pressure areas. E for electrolytes, so we should think, is this child at risk of having electrolyte imbalance, or do they have an imbalance of their electrolytes because of kidney problems, for example? And then think about their fluids and their feeding and make sure we're not fluid overloading the patients, and make sure we're optimally nourishing these patients. So we're not giving so much of their fluids as IV fluids, but we're giving most of it as enteral feeding if we can. Then think about glucose. Remember, if you are enterally feeding patients, usually their glucose looks after itself. But if the child's on intravenous fluids, then we may risk making mistakes with their glucose, either too high or too low. Then for H, think about the hematology, think of anemia or their risk of thrombosis or signs of infection on the full blood examination. And I for clinical signs of infection. You don't have to go through the entire alphabet, but I always think about patients like that. And if you get used to a systematic approach to thinking about them like that, not all patients, but those that are critically ill, then I think we won't miss things. So I just wanted to go through that systematic approach today and hope that's useful to you. And then maybe you should try it out in the next, critically ill patient you see and see how you go. So I'm going to stop sharing my screen now and see if anyone's got any questions. And yeah.
No questions, Trevor, but Prof, just to say that like in Goroka, when we were there, we were seeing these kids with respiratory distress. Yeah. And we had a benefit of an echo machine in the adult ward at the time, which we see these kids with elevated pulmonary pressures, and maybe a few of them we thought, hey, better go down to lay from this this altitude here, and pretty much maybe a couple of them improved, but we couldn't be sending all the kids down to the coast. But we had those kids around then.
Yes, that's right, isn't it? There's a lot of pulmonary hypertension in the highlands, and some of it is related to the altitude, I'm sure, and the hypoxemia that children get. But some of it's related to the severity of pneumonia, and some of it might be related to some chronic lung disease. But I think that we have to think what's fixable, and sometimes things can be fixable if we think about like nutritional deficiencies that might cause severe pulmonary hypertension, like thiamine deficiency or like scurvy. Not all children are going to respond to vitamin C or respond to thiamine, but they're easy thing. It doesn't hurt to give them those sorts of treatments. And I think we, oh, excuse me. Hello, it's Trevor Duke speaking. Oh, good, sir. Could I give you a call back in just a moment? Is that okay? I'll give you a call back in about 3 minutes. Okay, bye. Okay, I'm sorry. Yeah. So James, you're right about that. There are lots of patients still being seen that, again, some of them might have some responsiveness to vitamin C or thiamine. Oxygen particularly, they generally respond to oxygen. So, okay. Okay, well, look, if there's no more questions, thank you, everybody, for coming online today. I hope that's useful. It wasn't a very didactic talk, but I wanted to just outline a couple of interesting cases and how we might manage them. So thanks, everyone, and I wish you a good and safe week. And yeah, all right, that's all.
Okay, thanks, Prof.
Okay, bye now.
Thank you, Prof.
Thank you, Prof.
All right, bye, everyone.